Hi, I'm Dr. Rupa Vemulapalli, one of the gastroenterologists at UT Southwestern Medical Center. I'm going to say a few things about gastroparesis today. Gastroparesis is a condition where the stomach muscles do not empty normally in the absence of obstruction. In normal, healthy people, the strong muscular contractions of the stomach muscles, they pulverize the food that we eat and push the food into the small intestine for absorption and digestion. Gastroparesis is commonly seen in type 1 diabetes and is more common in women compared to men. Other than type 1 diabetes, there are some other diseases that can cause gastroparesis, and some of them are Parkinson's disease after stroke, scleroderma, myositis, autonomic nervous system disorders. Gastroparesis can also be seen after certain viral and bacterial infections, and also can be seen after surgeries that are done to treat peptic ulcer disease, surgeries that are done to treat acid reflux called the Nissen fundoplication, and after lung transplant surgeries. There are a variety of medications that can delay gastric emptying, and some of them are opioid, narcotic medications that are used to treat chronic pain, tricyclic antidepressants, blood pressure medications such as calcium channel blockers, clonidine, lithium, which is also used to treat depression. More importantly, marijuana can significantly delay gastric emptying and should be avoided. Some of the symptoms of gastroparesis are due to delayed emptying. One can experience belching, bloating, abdominal distension, weight loss, and nausea and vomiting.
I'd like to talk about the clinical presentation and differential diagnosis for gastroparesis. The overwhelming majority of patients with gastroparesis experience nausea. Other symptoms include vomiting, weight loss, postprandial fullness, abdominal discomfort, and bloating. The differential diagnosis for gastroparesis can be broad, but the most common mimickers include actual anatomical obstruction, rumination syndrome, which usually occurs in mentally disabled children and adults, psychiatric illnesses such as anorexia and bulimia. That can be challenging in patients with anorexia because some of them actually experience a delay in gastric emptying. So a high index of suspicion is needed in women, especially young women with altered body perception. Cyclic vomiting syndrome or cannabinoid hyperemesis. In these patients, interestingly, gastric emptying can be rapid in their symptom-free period, and typically the symptoms of nausea and vomiting can be severe and last for days or hours. Functional dyspepsia, although in these patients the abdominal discomfort is more of a predominant symptom than, say, the nausea, vomiting, and weight loss.
Hello, my name is Dr. Vivian Asamoah. I'm an integrative gastroenterologist in Katy, Texas, and I will be talking a little bit about how to diagnose gastroparesis. Very often, most gastroenterologists will find food retained in the stomach and have some kind of suspicion that this patient most likely has gastroparesis, especially if they fasted overnight. But the ideal gold standard is a radiological scintigraphic test that actually shows delayed emptying of the study. And ideally, we want a 4-hour test. So the test is done by radiology, and our patient has to usually eat about a 250 kilocalorie meal that's, with scintigraphic tagging on it, that is usually comprised of egg beaters, jam, toast, water, or sometimes a higher fat beverage like milk, which is more representative of the standard American diet. And the diagnosis is really to identify how much food is retained in the stomach. And if there's more than 60% of food retained in the stomach after 2 hours, and more than 10% of food retained in the stomach after 4 hours, then that is definitely diagnosis definitive diagnosis and diagnostic of gastroparesis, right? Other tests that we can sometimes see, also called gastric emptying tests, and they are, but very often they're much shorter in duration. So we're seeing 2-hour tests, and we're seeing tests done with liquids. And these are not as accurate as the gold standard 4-hour test, and very often reduce the sensitivity of the test. So ideally, you want to have that 4-hour test. Another test on the market that I think is probably going to gain a little bit of favor because there's no radiological exposure, so it's safe for children and it's safe for pregnant patients, is the carbon-13 spirulina or octanoate breath test. So our patient fasts for 8 hours, and then, they have their meal tagged with this, spirulina, and we are basically doing breath test collections over 4 hours to see when we first see that carbon-13 isotope reappear on breath test. So a pretty good test, not the gold standard, but a very helpful test as there's no radiation exposure. Finally, you'll often see described a wireless motility capsule study, the SMART pill. Not the gold standard again, because one, we think it's really looking at phase 3 of the migrating motor complex of the upper GI tract, and not so much the gastric emptying, the gastric contractions. So it gives us some idea, but it's not really a representation of what happens when you eat, right? When you're eating a solid meal. So those are the 3 tests that we use to diagnose gastroparesis. The first one being the radiological scintigraphic test, the gold standard, the 4-hour test. The second one being the carbon-13 spirulina or octanoate isotope test, breath test. And finally, there may be a role definitely for the wireless motility capsule. One thing that's really important before doing these tests is that we have to be off all opiates, anything that may affect the motility, antiemetics, and be off all of these medications for about 48 to 72 hours so we get accurate results in terms of the testing. And another thing that's really important is making sure that our blood sugar is well controlled and well under the value of about 250, 275 before doing these tests, because hyperglycemia in itself, which is high blood sugar, can also reduce the motility of the stomach. I hope this was helpful, a little bit about how we diagnose gastroparesis.